Are we okay in the back? Good? Okay up there in the wings? Yes? Okay, guys? Yeah? Okay. Good. All right. Let's get started. We've got a very important topic today. But before that, one of the students in the class prior to this left a blue laptop bag with an HP computer in it, right up here. If anybody's seen it or has any clues, there's the kind of semi-distraught undergrad. So if you know, she's tried to find it, but she hasn't had any luck. Okay, so she'll be there. All right, so today we're going to talk about, we spent 2 lectures on epilepsy. The second lecture was really a fun lecture for you from Dr. Chevelle. I'm not asking you to remember all the things he talked about. The bottom line of what he was telling you is if you have a kid who's 9 years old and they come in because they're having seizures, if you can figure out the semiology of the seizure, in other words, what was the prodrome, how did it start, you might be able to figure out exactly the location they needed to focus on, because many, many people are MRI negative, right? They've got seizures and their MRI looks normal. You have to find the onset. So that semiology, if it starts with a hiss and then it generalizes, maybe it's in auditory regions and so on. That was the gist of what he was really talking about. So today we're going to talk about an incredibly common clinical phenomenon, which is head trauma. And head trauma, people hit the emergency room last year in the U.S., roughly 2.5 million people ended up in the emergency room because they had head trauma. Many were relatively minor concussions, but many were even fatal. So there's a large, large spectrum. There was roughly 60 or 70,000 deaths last year from traumatic brain injury, and at least 100 or 200,000 severely, permanently incapacitated people. So the first thing is, has anybody personally in this room had a concussion? Okay, look at this. Okay, so let's actually do this. Do you mind telling us what do you remember or not remember? So you may not remember anything.
I was a little kid. I fell off the monkey bars and hit my head. I passed out. I went to the emergency room and sat in the waiting room for like 11 hours, and then they did a cognitive exam, and we're like, okay, you're fine.
No CT or anything?
No.
How old were you? Little?
Probably 7?
7. Okay. How about someone older? What happened?
When I was 16, I was playing basketball and got thrown to the ground by a girl much bigger than me when we both went up for a rebound. And I passed out and then was taken in an ambulance to the hospital and then had a CT and had to get surgery.
You needed surgery?
Yeah.
Okay, so you had more than just a concussion. Yeah, for sure. Okay, did you have much residual? How long did it take you to get back to feeling normal?
Like
2 months. Not bad, because sometimes it can be never, and so that's great. Anybody else? My concussion was a basketball, and I was in the 8th grade, and I was going up for a rebound. Someone undercut my legs. It wasn't really super, and I just went back and hit the back of my head. I don't really remember anything other than something happening when I was in the air, but I was told someone took my legs out. And I was out of it, not long, maybe 30 or 40 seconds, but I was woozy and I couldn't finish the game. Who else is in here? Who else would? Okay, back here. Just give you the spectrum. So one person was pretty minor, one was serious, requiring surgery.
I was in the 7th grade and I was playing basketball during recess, and I did a slam dunk, but my fingers slipped from the basket, and so I fell straight on my head, straight on the concrete. I got up right away and went to the side, and then I saw everyone else was asking me how I was doing, and then I said I was fine, and then all of a sudden I remember feeling like this sensation of everything around me just going in circles.
That vertigo.
And then, and I don't remember what happened after that.
So you went out. Did you go to you were taken to the hospital?
Yes, I was taken to the hospital. An MRI was done on me and everything. I didn't have any surgery. I didn't have any type of...
You landed on the back of your head.
Yes.
Yeah, that's a very, very common, is landing on the back of your head. That's the NFL quarterback, right? They get tackled and they land on the back of their head.
Yeah.
Okay, so how long did it take you to get fully back to normal?
I was told it took about 10 minutes.
No, but I mean, will you feel it totally normal a week later, or did you have lingering symptoms?
No, I was told.
Okay, did anybody have lingering symptoms from a concussion? Anybody here? Yeah, okay. One more. This is good because you can see this is a pretty common event. Look at all the people in the class who've had this happen to them. Thank you.
When I was in 8th grade, I was skiing and fell and got a concussion and didn't know it, and then went back out a couple days later and got another one, and had lingering symptoms for 2 months. I was dizzy and couldn't see straight, and I've never had problems with my vision, but I had problems with my vision for about a month and a half afterwards.
I know it's a while ago because you're an older woman now, but did you feel fatigued? Do you remember how you felt in those 2 months?
Yeah, the doctors told me that I had to sit in a dark room and not use my brain. So I remember for the 2 months I just had to lay in bed pretty much, and
it's like
I was
injuring
tired.
your arm, right? If you injured your arm,
Yeah.
you pulled a muscle in your arm, you put it in a sling, you wouldn't use it. Your brain in some ways the same after you've had a concussion. Okay. Well, thank you very much. So you can see this is a pretty common problem, and it can range from relatively minor to really incapacitating for weeks, months, or even sometimes your entire lifetime. So let's see if we can figure out what's going on. What's going on? There it is. Okay. What's going on? Okay. This is not working, of course. Fine. So the pathophysiology of traumatic brain injury, there's a divide of the two things that happen to you. And one divide is diffuse injury. What's a diffuse injury? That means most of the people in this room had a diffuse injury. They didn't, maybe the one woman over here needed surgery. I don't know what the details were, but a diffuse injury means the connecting fibers that connect your brain. Remember all those things we looked at with diffusion tensor imaging? They're impaired. And that's because, as you'll see, when you're... What happened?
I plugged it in.
I don't know. What do you think about his affect? I mean, you liked it probably. Okay. Thank you very much. It really, thank you. I really, next slide. Okay. Oh, I see. The other problem is I didn't have this on. I must have hit my head this morning. So what happens is the connecting fibers get damaged, basically. And typically, and I'll show you what happens, it's caused usually by a significant fall with acceleration or deceleration. Usually the fall is about at least 6 feet. But if you're playing basketball and you're 5 foot tall and you're jumping and someone takes your legs out, that's enough, right, to get a very serious traumatic brain injury. And it may be diffuse, where they're stretching the fibers all over the place. And these are the axon coating, the myelin coating on your axon is susceptible to this compression and expansion. Or you can have actual focal damage. And a focal damage means your brain is bruised. There's actually a mechanical tear in the brain, just like if I took you and punched you in the shoulder and you got a big bruise. There'd be blood in your muscle. Now, in the muscle, luckily, you've all had muscle damage, you've been hit, you've had bruises. All the blood gets resorbed and your muscles don't die. The problem is blood in the brain. The brain doesn't tolerate it. It sets off cascades that actually kills tissue. And I'm going to show you some real examples of this. But I'm going to pass this around. This is a real skull. And all I really want you to do is to notice a couple things. Most of the skull, the top part, is incredibly smooth. You just take your hand and you'll feel it smooth. But if you look inside where your brain sits, you don't need to have, you can just take your hand, and every time you feel a sharp ridge, that's going to be a potential point that when your brain hits it, it will get torn, just like if your muscle ran into a piece of wood. So I'm going to pass this around. I really want you to feel these things because these are all quite critical in the pathophysiology of traumatic brain injury. So why don't we just start here? Okay? Try not to drop it. It got dropped a few years ago, and there's 2 chips in the skull. It's a little, unfortunately. Okay, So let's talk about contusions, and then there's hematomas. We talked about hematomas in stroke, and hematomas in stroke were blood bursting into the brain. Hematomas with traumatic brain injury, it's used a little bit differently. It basically refers to a collection of blood between the brain and the skull. And they either occur in the subdural space under the dural membrane or above the dural space, epidurally. And they grow very quickly, and they press on the brain, and they produce all kinds of problems. So how common is this? Incredibly common. I think I mentioned to you my daughter's grandmother, basically 97, February 16th, fell in her extended care facility, hit her head, just like the lady here did, on the back in the bathroom, which is very common, slip and fall. She was wide awake. When they found her, she'd been out probably. They came in and they said, well, we got to call 911. She said, don't call anybody, because if you call anybody, they'll think I can't live independently, and they'll put me in a different place in the basic facility. Well, they did call people, and when the ambulance came, she started to slip into a coma. By the time she hit the hospital, she was in a deep coma. The bottom line, I'm not going to go into details, she died. This is a relative, just died. So this is a common occurrence, and you want to be very, very careful about not missing these. Okay, so is this lighting okay? Or is it, because I don't have many films. So the axonal injury is either compression or boom, boom, your brain gets compressed and expanded, and it can lead to tearing and tension. This is axonal shear injury. And everybody who had symptoms here that lasted more than a day had some degree of minor axonal shear somewhere in the brain. Usually you don't see it in minor cases. You don't see it on the 3T. You pick up a few more cases on the 7T. So let me just show you what's happening to your brain during this. And I'm going to show you a movie. So your brain, if you took it out of your... What do you do? Okay, good. Sorry. Yeah, that's right. Room controls. There, computer. Nice, eh? Basically, if I took the brain out of your cranial vault in a fresh autopsy and I put it in my hand, it would feel like you had a Jell-O mold in your hand. That's how friable your brain is. It's incredibly soft. It is not designed to sustain traumatic brain injury. Evolutionarily, I think if you fell out of a tree and hit your head, too bad. The gene pool moves on in another direction. But in the modern world, there's a huge number of traumas to your head. So take a look at this movie. This is from a colleague down at UCLA that he put together, and he's showing you, he's got a brain in a cranial vault. It's not a real brain, but he's made a model that's of the same density of the brain. You're going to see him hit the skull, and you're going to see the brain oscillate. Do you see that? That's what's going on, right? Your brain's oscillating back and forth with trauma. And one trauma usually kicks off 2 or 3 oscillations inside the brain. And every time it oscillates, and I don't know where that skull is. Where's the skull? In the great... Who's got it? Where would the damage be? Put your hand in that skull. Put inside the skull. Feel where there's a bony ridge. Where? Yeah, right there. Sphenoid ridge, damage there. Where else? Where else? Exactly. The olfactory, this bone right here, tears your orbital frontal cortex. And then where's your temporal lobe go? You're doing good. Yeah, it's up here, right here. Let me just show you. Every time that thing oscillates around, it hits the back of your skull, which is smooth, so you don't get any damage. You may see stars, but you don't get damage. So if your visual area of your brain was exposed, actually, and you were awake, and I just went bing with my finger, you'd see stars. So you see stars, but you don't damage. You bounce forward, and you hit these bony ridges. There's 3 of them, sphenoid and ethmoid ridges, and when you hit those, you tear your brain. So pass that around and feel these things. It'll give you a really good feel for it. That's what happens. That's what you want to stop. Okay. When that happens, various things can happen in the brain, such as tearing of fibers. So here's an MRI scan. Here's an MRI scan with some tearing in the white matter. Here's a hemorrhage in your corpus callosum. And generally, the structures in the center of the brain are particularly badly affected by this tearing forces, but they can be very extensive throughout the brain. Sometimes you'll get axon tearing in your brain stem. So here's your brain, here's your pons, and here's an axon injury here. So let me just ask you, based on where that injury is, and based on the very early part of the course, when we talked about coma, is this person awake or in a coma? What? In a coma, right. Why? What structure's damaged? What area in the brainstem wakes you up? This morning it all fired at some point and you went, choo, and you woke up. What's the structure that wakes you up? It sits right here in your brainstem, right there. Anybody? The reticular activating system. Remember we talked about that? You put an electrode in a sleeping animal, you stimulate it, the animal wakes up. You need it for maintenance of arousal. So this patient, even though the lesion is relatively restricted to the brainstem, they'll be in a coma. So here's this idea of the coup contra coup injury. And I showed you in the skull that the top and the back is smooth, the front has got bony ridges. So it doesn't matter where you hit. It could either be a direct coup injury, which means direct coup injury, which means you fall and hit the frontal lobe and you directly damage these frontal temporal structures, which we'll get into in more detail. Or if you fall on the back of your head, the same structures will be damaged because the brain will stop on the floor, it'll bounce against the floor, it's smooth here, it's not damaged, it goes forward, and it hits those bony ridges, which you're all going to feel, and you tear your brain. It's really as simple as that. It's not complicated, the mechanism. And again, what you've seen in the skull that's being passed around, we have this ethmoid ridge, which is a very sharp ridge right where your olfactory bulbs are. That's why it's so common to get damage to the olfactory cortex and often end up with social and emotional regulation problems, which we'll talk about later in the course. Or the sphenoid ridge here, that's where your temporal lobe sits, basically, and that's a very sharp ridge, and that also, you hit that and you can damage your anterior part of your temporal lobe, which includes your amygdala, which is your emotional saliency detector. So you can see these patients are really at risk for getting problems with social and emotional control as a residual of these injuries. Very, very common. Again, this is just the real life, and you're getting the skull. We've got our key 3 ridges that you can get damage on, which is the ethmoid ridge, which is the sphenoid ridge, and which is the petrous ridge, as you can see here. And the brain just sits down in there. Now, here's a little movie of what this looks like, and I've already shown you the doctor from UCLA just hitting the bone, and you're hitting the skull, and you're seeing the brain oscillate. Here's a cartoon of it. So you hit, boom, boom, boom. So your brain is oscillating. You've hit something, your head's going back and forth, your head stops, your brain's going back and forth inside of the cranial vault. You hit both the back, you hit the front, but in the end, the only place that get injured is the front, not the back. And you only get the injury in the front. It's really simple. It's biomechanical. It's because of the way your brain is packed into the skull. You have to realize that, you really had to take a lot of information and develop gyri and sulci so you could pack it into the skull. As my favorite person ever, Marion Diamond, said, if you took the brain, if you didn't have gyri and sulci and just had gyri, your brain would be about as big as a medium pizza. So the brain is packed in there, and it's packed in there tight with all these bony ridges, again, paying no attention at all evolutionarily to the idea that you might be more susceptible to traumatic brain injury. I think it's just an evolutionary way to not have a huge head because that makes you unstable, right? Your center of gravity becomes too high. So that's, I think, in part why we've got this, highly encephalized gyral and sulcal pattern. Okay, what's the residual of this? If you go to Highland Hospital on Saturday morning, And Sunday morning, which I did for many years, we got the trauma board that you make rounds at 8 o'clock, and this is a very, very common CT scan. Right here. Whoops. Right here, there's a CT scan, and you can see white on the non-contrast CT scan. So that's blood. That's an acute contusion in the frontal lobe. And as you see when you feel the bone, you'll be able to figure out exactly how that ethmoid ridge tore that person's brain. Now, this person is at risk, obviously, since we've talked about this, for a couple things. One, seizures, right? Common cause of new onset of seizures is traumatic brain injury. And two, social emotional regulation problems, changing in personality. You have to be really careful because they need to be warned about this and they need follow-up. If someone came into the emergency room and they had that same lesion right there, but it was in Wernicke's area in the temporal lobe and they had a language problem, they'd have massive follow-up by speech therapists and this and that, you name it. But if you come in with an orbital frontal lesion and you've been knocked out for 2 minutes, you come in, by the time you hit the ER, you're kind of awake and alert, and everything's working, your Glasgow Coma Scale's 15, and you've only got this contusion, and the docs know it's not going to be fatal, you could get sent home without any follow-up. It's not the appropriate thing. The person should be sent home with follow-up to be followed by professionals who deal with people with traumatic brain injury and the ensuing problems they're going to have in cognition and social functioning. The one woman up there, right, she had 2 months of fatigue, right? I mean, that's a long time. It can be, and it can last, much longer than that, if not permanent. This is a worse outcome. Of course, this is a post-mortem case, and you can just see the contusions here, which I just showed you a small one here in another case in a CT scan, and in the anterior temporal lobe. So you've got orbital frontal cortex and amygdala. You've got the core elements of your emotion and social regulation system are frequently damaged. We've known about this forever. This is not news. Basically, this is a study from 1937 where a pathologist simply, on a cartoon of the brain, with 40 cases traced out where he found the lesions in fatal cases of traumatic brain injury. And I think you can see quite clearly that it's orbital frontal and anterior temporal. There's a few cases that may get a contusion or two in the back of the brain, but not many. And the reason is the back of the brain is smooth, so there's nothing to tear or compress the brain. It's really a mechanical issue. And this person is the person I'd like to meet, but I don't think he's around anymore. This is a neurosurgeon, again in 1937, who basically took a skull and put a Jell-O-type mold into the skull. And before it completely solidified, took the brain, the skull, and shook it like he was shaking a martini. And basically then opened up the skull, and lo and behold, the mold had damage in the orbital frontal and the anterior temporal. You can see how these things all beautifully come together in terms of where the damage is. Now, of course, what you want to do is avoid the damage, right? But you never know about these kind of things. I was driving home last night on Arlington, and there was a mother, a 10-year-old, and a dog crossing the street in a crosswalk. I stopped my car. Some lady not paying attention, going at full speed, just bang, hits me. But you never know. Accidents happen. Nothing happened to me. She was upset, let's just say. Okay, so this is a fatal case, and I just want to keep hammering this into you. You can see this is of a fatal case. You can see this is bloody contusions here. And if we cut through the brain, you can see the massive hemorrhages in the temporal lobe here. These are really, pretty intense. You can also, for those of you interested in epilepsy and you might go into medicine, if you look here, see that there? See that there? And see that there? Those little flecks of blood in the cortex, those are little flecks of blood. They would be below the resolution of the MRI scan. You would not see them. But they're there. And they may lead, even this little contusion here, in someone that wasn't a fatal case, of course, could lead to the development of seizures. So you see people who have been post-traumatic, right? They know they had some traumatic event, and then 6 months or 8 months later, they start having complex partial seizures, or whatever kind of seizure they might be having, and you do an MRI scan, you don't see anything. but there's something wrong. And you can see they're just below the resolution of current scanning technology. So what happens with orbital frontal damage? Here's one of our cases. He's actually in our research cohort, this big orbital frontal expanse. This is a chronic case, not the patient I'm going to show you. And you can see all that encircled area there has been resorbed. It's gone because there was a big contusion there. The brain doesn't like blood. For the MCB folks, you can imagine all the tissue cascades that get set off. Cells die. The brain cleanup system comes in, and within 6 months, you're left with a hole in the orbital frontal cortex. This is a patient that I followed for many years who, when he was 18, unfortunately drove a scooter into a telephone pole. So he had he didn't fall and have a jolting coup contre. He went straight in and had a crush injury of his orbital frontal cortex. You can see here's the damage here. You can see this extensive damage in the orbital frontal cortex. Now, interesting, this gentleman actually has a very high IQ. His IQ is around 130. He's smart. We tested him on a lot of things, and he didn't have any problems with anything in standard testing. I ran into him because he was having trouble getting disability. He couldn't hold a job, right? That was the reason I saw him in clinic. And the bottom line is the reason he couldn't really hold a job is because he has this extensive orbital frontal damage, and he's impulsive and makes bad decisions in life. So let me just show you this gentleman. What's going on here? Why isn't the audio working? Extron speakers. I don't know what to tell you. Okay. Well, the HDMI has the audio. It should, yeah. But what the heck? We'll go old school. Okay. Okay, let's take a look at this gentleman. Let's see if we got it. What's going on? Maximum volume. It's not muted. No, that's mine. That can't go any higher. Is impeding that. Obviously.
I don't have.
All right. Thank you. What was it?
This laptop one was unselected, so somehow when we...
Okay. All right. Did you notice that you were attracted to a lot of women, or just not attracted? What was?
I was attracted, very much so.
To a lot of women.
Yeah, I touched things 4 times.
Acquired OCD, very common.
Put things in my mouth. Everything's an even number. All my 4s, 8s, or 16s. I count license plates. I count flags.
What's the problem that you're not what you thought you would be prior to the accident? Something is impeding that, obviously.
I don't have a whole lot of concentration. I don't like being told what to do.
But high IQ.
I've had trouble maintaining a job ever since the accident. I am not that perceptive. I'm naive.
You can't read people who can still take advantage of you on the streets?
I believe people.
So you haven't had any fights. You haven't been arrested in the past 20 years?
Oh, yeah, many times.
What for?
Twice an assault against my wife. Although, like I said, I need to replace the door. The only thing that got beat up was the door. And for improperly using somebody else's credit card. And I once opened a checking account and bounced $2,000 in checks in a week.
Was that the right thing to do?
No, of course not.
Any other arrests?
I had a DUI, 2 DUIs, and a reckless. One in Hawaii, one in Washington. Seems like there should have been more.
Yeah. So if you show this video to a psychologist, psychiatrist, they're going to probably say the person has a borderline personality disorder or is close to a sociopath. It's not true. This is the result of a traumatic brain injury that could happen. The same thing could happen to any one of you. God forbid you sustain that injury. There's one thing that he said that tells you he's not a sociopath. What did he say? What? He knew it was wrong. Sociopaths don't care. He actually, his behavior is reflexive. It happens almost automatically. In fact, we've studied these patients, and when you give them orienting stimuli, if I give you some new stimuli, let's say your brain response is this big, their brain response is this big. And if I repeat an orienting stimulus to you, it habituates. If I repeat an orienting stimulus to an orbital patient, it doesn't habituate. So they're dysregulated, but after the event, they feel bad, and sociopaths don't. So you see, a sociopath, you don't exist to a sociopath or psychopath. You're an item. He knows people exist. He just doesn't know how to regulate his behavior. And this is why I'm going to put this up here, because this is another study from UCLA, now USC, no, Iowa, now USC, showing, then they call it acquired sociopathy with these lesions, 9 patients, and patients without damage here don't have any of the symptoms this gentleman has. I really hate this term because they are not acquired sociopaths. This guy's not a sociopath. So, and I'm not happy when neurological patients are basically given some tag that's not true. With that said, you saw the patient, he's not a sociopath. You can get, so then the other thing you can get in terms of these coup contra coup contusions is you can get skull fractures with damage. So here's a skull x-ray. We see these all the time. You shouldn't see these jagged straight things. See every one of those? Every one of those is a bad skull fracture. When you have that kind of skull fracture, you know the person's had very serious intracranial pathology. And it might be a combination of contusions and axon shear, and maybe even an epidural or subdural, which I'll show you what those are in a little bit. So you can get really complicated things with a trauma. Here's a case that I saw at Highland. And this is a nurse, and some guy broke into her house about 4 blocks from here. Virginia? Yeah, it's about 4 blocks. Attacked her at night with a hammer and actually hit her. She got a depressed skull fracture. You can see the contusion under there. It's really interesting. The guy got caught. He was a Berkeley councilman. And then he had one of his witnesses beheaded. And then he fled the country. And then he was eventually, you can't make this stuff up, right? And he ended up in prison. Hopefully he's still there. That's a depressed skull fracture from a hammer attack. Yeah. Did someone ask? Yeah, what? What was the white thing on that image that wasn't? Where? Whoops. Here, that's just some blood in the subcutaneous tissue, right? I mean, that's where the hammer hit. But you can see that the depressed skull fracture and a contusion there. So now next thing, so we've got contusions, we've got stretching and tearing of fibers, axonal shear, and then we have subdural and epidural hematomas. And these are the parent's nightmare. Like the couple of the kids in this room, right, when you were little, right? When you were little kids, when you're 7, 8, 9, you fall off your bike, you get hit in the playground, and you hit your head, and you're knocked out transiently. You don't know. Maybe it's going to be fine. Nothing's going to happen. Or maybe you're starting to leak blood between your brain and your skull. And then your neurological status deteriorates, like the grandmother who died, right, from a large subdural hematoma. So what you need to know about to understand this is your brain, and you basically have these little connecting things, and you have here's your dura. So you have the duras between the bone, and there's dura, and then you have your subdural space in here. So either one of these spaces can accumulate blood and press on the brain, and they're very susceptible to being torn. And they're particularly susceptible in older patients because by the time you're 75, the average amount of decrease of volume of your brain is about 100 grams. And your starting is about 1,300 grams, which means your brain is shrunk a little bit, which means these connecting small veins are actually stretched. And they're very susceptible to any more damage. They tear easier because if you think about it, they're kind of already at a tension point. So what happens? You could get hit with a blow, you could fall, etc. There's all kinds of misery that can happen to your brain. And what happens is, the first thing I want to talk about is an epidural hematoma, because some of you will have kids, and this is the thing you're worried about if they get knocked out, because there's usually a lucid interval, right? Kid wakes up and is fine, and then they don't deteriorate for an hour or two. Right, so the question is, what do you do? Well, the first thing you do is you take them to the emergency room and get them evaluated, make sure there's nothing that looks bad going on. So what happens? This is your dura. This is a really tough fibrous covering of your brain, the dura, right? It goes all around your brain. So there's a space. Epidural means above the dura. Bone, dura, blood. And in a minute we'll talk about subdural, which is blood below the dura. What happens to supply the blood to your dura? There's an where's that skull? Is that floating around here? If you hold, who's got the skull? Hold it up to the light. Can you hold it up to the light? No, I want to show. Well, when it gets back down here, I'll show you. Right here, sitting right here, your skull is incredibly thin. It's really only a couple millimeters thick. Right? Up in the back, it's big, thick bone. What happens is there's an artery that comes up called the middle meningeal artery that provides all the blood to your dura. And it sits, there it is, coming up. The problem is it's very susceptible to a skull fracture damaging it and cutting it. And if that artery gets damaged, it leaks blood, you get an epidural hematoma, the person slowly lapses into decreased consciousness, and depending on how much the brainstem and the reticular activating system is impaired, they will eventually slip into a deeper coma. And you got to do something really quick. If you get somebody and they're out on 80 and they're having a car accident and they come in the hospital and it's a 22-year-old and they basically have they got various neurological signs saying they're deteriorating based on what we discussed in the neurological exam, and you do a scan and they got a big epidural, if you take it out within 4 hours, you're probably going to get close to 100% recovery of function. The longer from that 4-hour window you are, the more likely there will be permanent damage from pressure on the brain. So this is a real medical emergency. And that's why trauma centers need an in-house or closely on-call, preferably in-house neurosurgeon, right, to deal with these kind of problems. You can't have a neurosurgeon on call for Highland Hospital or who's out in the bay sailing. It's not going to work. They've got to be there. That's why you have level 3 trauma centers, emergent care. Or you could have a subdural hematoma, and these can be quite extensive, and they exist below the dura, and they're tearing of these little veins, and here's an acute one. You can't see it. It's not the greatest resolution scan, but you see, I can see the gyri and sulci here, and here's the bone. And for some reason, I don't see anything here, and the bone looks thicker, but it's not really thicker. It's because there's blood here. And if I actually do a Hounsfield unit on it, I'll be able to tell it's blood. So that's an acute blood. Blood eventually goes from white to gray to black on a CT scan. So this is the same epidural in a same type of subdural hematoma. Chronically, the person's coming in, they'd had a head injury a month ago, and they didn't deteriorate and go into a coma, but they have been functioning well. They're not thinking clearly. They're not with it. And you do a scan, you say, my God, they got a chronic subdural hematoma, big hematoma. And if you notice carefully, see how I can see the sulci here? I don't see them here because they're all compressed. And this will be taken out, and the patient should do just, very well. Then another thing that we do when we get somebody in to the hospital and they're really deteriorating quickly, to really relieve pressure, we do a decompressive hemicraniectomy. Sounds crazy, but that's what we do, and it works. You basically drill a bunch of holes in the skull, connect them with a saw, take off the skull, take out the blood clot, and let the brain, which has already been hit, it's going to swell a little bit, let it swell without any pressure from an intact skull. You wait 2 to 3 weeks, the swelling in the brain goes down, we put the skull back on. The skull can be kept frozen or it can be kept in the peritoneal cavity. This is a routine procedure. We do it all the time. Just had a friend's kid. You know where Calusa Avenue is? Calusa in Berkeley, just a street. She's crossing Calusa 9 at night. Nice 26-year-old woman. Some guy hits her, flips her, bang, hits her head. Bilateral subdurals. She ends up with and she was an extremist. She was going to die if they didn't do anything. They did bilateral hemicraniectomies, took out the subdurals on both sides. She had a prolonged hospital course. She's back at home, and she's doing pretty well. She's not 100% yet, but she's alive and doing pretty well. She interacts with her friends. She can talk. She can walk, etc. So this is a decompressive hemicraniectomy. This is what it looks like. And you can see there's no skull. And that's what the patient looks like. And for a while, Colin, we were bringing these patients into the lab because they didn't have the skull back on. The standard used to not put the skull back on for 6 months. So we actually brought them in, and they came in as research subjects because we didn't have any skull. We just had the brain with a dural, and we could record, high-frequency signals. So we thought we had a new model. But then they changed the criteria and started to put the skulls back on in 2 weeks, which is great for the patient. And I'm not going to go into this. This is, okay. So what's the clinical presentation of a mild traumatic brain injury, which many of the people here had? Okay? What is it? Pretty simple. Initial loss of consciousness, seconds to minutes, but not longer than 30 minutes. If you're out for longer than 30 minutes, it's not mild anymore. Yes? What they do, it's a good question. What they do is they take it off. It's off. They preserve it somewhere to put it back on. Sometimes the skull is so smashed up, you actually have to put in a titanium plate eventually. You're taking it off to relieve pressure so the brain can expand. And then they get the dura sewn back on in the skin. And when we were testing the patients, I think 7 or 8 years ago, they were all outpatients. They'd come right into our lab over here in Barker Hall. They typically wear a helmet all the time, because you don't have any skull on one side, and you can actually, when you take the helmet off, you can see the brain pulsing, because there's just the dura, the brain, the dura, and the skin. Period of confusion is usually just minutes to hours, can last substantially longer, but usually it's pretty short for a mild traumatic brain injury. Often, as you heard from people here, combinations of headache, dizziness, spinning sensation, vertigo, nausea. There's a whole range of symptoms that go with this. Probably one of the most persistent ones is fatigue. Patients just don't feel they're lacking mental energy, and that can last for 2 months, 3 months, 1 week, 1 year. In some percentage of cases, it never really clears up, and they never go back to a normal lifestyle. The general neurological exam, motor, sensory, cranial nerves, they're normal. Right? You don't see anything on the exam. The follow-up presentation, cognitive deficits, you heard them from the people here. Attention, memory, executive function. And then these other ancillary findings, they don't sleep well, they end up getting symptoms of depression, anxiety, and all kinds of ancillary symptoms. So these are the kind of things, and what we want to do is prevent them, obviously. So what we're going to do next, and I'm going to stop here and finish this up next time, I really want to talk to you about chronic traumatic encephalopathy, which is this disorder of repeated small concussions that people can get playing football, playing soccer, playing ice hockey, etc. So we'll do that next week. But again, the recovery is usually within 3 months, right? The longest here we had was 2 months. Severe, months to years. Older patients always take longer to recover. A 60-year-old with a concussion is going to be impaired for a longer period of time than a 20-year-old. And up to 10 to 15% of mild traumatic brain injury, which is what was described here, can be symptomatic a year later. So we'll stop there, and we just have a few more things to go over, but we're going to start with chronic traumatic encephalopathy, this basic scourge that we're seeing in the country, and then we'll merge right into brain tumors and finish that component up, hopefully on Monday. Thank you. Good luck. That's what I'm thinking. That's easy for me to say. But you're welcome. Where's the skull? Can I get the skull back? Skull. Who's got the skull? Yoo-hoo. You got it? Okay, good. Oh. That's half of it. Okay, we got half of the skull. We're looking for the other half. Going once, going twice. Hello. Excellent.
I didn't get a chance to.
Oh, it didn't even make it down this time? I'll bring it in the next time. We'll get it there. See here, look at what I'm talking about. Look at the light. Look, see that's in there?
Yeah.
That's where the artery is. Huh. Right there. And that's why you get a skull fracture. Just hold it up to the light. You can just see it. Here, look through here. Look through the light. See here? How thin it is here? Yeah. It's super thin.
It's like really thin.
That's a danger spot.
And the back as well, like right here.
No, the back is thick as a brick.
No, I mean right here. Like right here. It looks
it's really
No, that's not really. There's a little bit. If you hold, you can tell right there.
Yeah.
Right, but you don't typically get fractures there. You get fractures here. That's where it likes to fracture. And then that middle meningeal artery is sitting right here, so it gets torn. You can see the groove from it coming up here. And that's it. That gets torn, and your kid's going to go on. They start bleeding. But you can fix it.
Right? Orbital, yeah.
Parents
And this must be the
freak out.
temporal.
Febrile seizures and head trauma. Not good.
So the easiest damage is here and here.
It's here.
Yeah,
and
exactly.
Then
You
here,
don't
right?
need to. You can just tell. That's where the orbital frontal damage are. Feel that thing. It's sharp. I'll bring it in. Yeah. And then this is where the temporal lobe sits, and that's sharp, right? And that's basically your petrous ridge, and that's sharp.
It's like a
that's
shark
all you
tooth,
need to
Leslie.
know. You've got the whole pathology of contusions just by knowing where those ridges are.
Why is it so sharp? Like why would it
Why
be
would it-
designed that way?
Why would we evolve this
Why
way?
don't you send an email to either God or the person who thinks he's God, Donald Trump, and ask them
Oh my
what the cause is? And if you get an answer, let me know, okay? Yeah, no. Oh, it's got to be Trump. He knows more than Darwin. Darwin's a stiff compared to him.
Okay, so
What's this up, guys? Yeah.
clarification
Everybody loves
on so generalized and focal are not like two ends in the same axis, right? Because you can have an absence seizure that is not the whole brain, but you're still losing consciousness.
Yeah, all those interesting absence seizures might actually look at you very discharge. Those kids actually, when you're recording, they're spiking everything.
Okay.
But they're not.
Then it
They're
is
not jerking. See,
Yeah, exactly.